Welcome to This Explainer. Today, we're unpacking a reality that bridges incredible clinical engineering with profound human endurance. We're looking at end-stage renal disease and the fascinating yet grueling reality of hemodialysis based on our source materials. It's a journey into both complex machinery and the human spirit.
Okay, let's dive into this. Think about it for a second. What happens when a machine can actually replace your organs, but demands your entire life in return? It's a pretty stark paradox, right? On the one hand, we have the precise, miraculous engineering of life-saving medical technology. But on the other, we have the exhausting, tethered reality of the human body that relies on it just to survive.
Section 1. The toxin problem. The biological threat of kidney failure.
So we need to start by setting up the massive biological problem that makes this mechanical intervention absolutely necessary in the first place. 850 million. That is a staggering number. It's the estimated amount of people worldwide affected by kidney disease, which actually represents a global prevalence exceeding 10%. When the kidneys begin to fail, the body literally loses its natural filtration system, creating a cascade of systemic crises.
And that leads us to a condition known as uremia. The crucial point we need to grasp here is the underlying logic of kidney failure. You see, when impaired renal filtration fails to filter out metabolic waste, particularly a compound called urea, it results in the systemic accumulation of these really nasty uremic toxins. It creates a highly toxic environment inside the body that is quite literally life-threatening.
And these uremic toxins cause some absolutely devastating multi-organ symptoms. We're talking extreme fatigue, anorexia, nausea, altered mentation, which is basically cognitive decline, and severe muscle cramps. But there's also pruritus. This is a persistent, deep itching, and our sources show this distressingly affects anywhere from 53 to 70% of patients on hemodialysis. It's something that significantly degrades their quality of life.
But hey, the toxins aren't the only threat here. Fluid overload is equally lethal. Without functioning kidneys to maintain that delicate fluid balance, excess water just builds up. This dangerously increases cardiac preload, which is essentially the stretching pressure on the heart before it pumps, leading directly to left ventricular hypertrophy, hypertension, and ultimately fatal heart failure. The body effectively begins to drown from the inside out.
Section 2. The mechanical solution. Engineering an artificial kidney.
This brings us to the actual medical marvel of the hemodialysis machine. It's genuinely incredible how clinical engineering replicates biology here, and this brilliantly illustrates the process. Step 1. Blood is withdrawn using a peristaltic pump. This is a highly specialized pump that actually mimics natural bodily rhythms. Step 2. Inside the artificial kidney, the blood and a cleansing fluid called dialysate move in opposite directions across a semi-permeable membrane. This countercurrent flow maximizes the diffusion gradient, effectively pulling those toxins right out of the blood and into the dialysate buffer. And finally, step 3, the cleansed blood is safely returned to the patient.
Now, to handle that deadly fluid overload we talked about earlier, the machine uses a really precise process called ultrafiltration. It essentially relies on exact hydrostatic pressure, using fluid dynamics to literally push the dangerous excess water across the membrane and out of the body. But it is a delicate balance, guys. If the machine removes this fluid too quickly, the patient can experience severe muscle cramping and really dangerous drops in blood pressure.
Which brings us to a really critical question. Why must the blood flow remain continuous during this highly precise mechanical process? I mean, think about the delicate nature of extracorporeal circulation, taking blood entirely outside the human body.
Well, the massive risk here is intradialysis circuit clotting. When blood is exposed to the artificial tubing of the machine, its natural biological responses to clot. If the circuit clots, alarms are going to sound, the treatment is critically interrupted, and in severe cases, the blood trapped in the machine can't even be returned to the patient. So preventing this clotting is an absolute matter of life and death, requiring constant, vigilant monitoring.
Section 3. The vital connection. Tethering the human body to the machine.
So, we've seen the biology and we've seen the machinery. Now we need to look at the physical bridge between the two, how doctors actually access the bloodstream. Generally, doctors rely on two main access methods. First, there's the arteriovenous or AV fistula, which surgically connects an artery directly to a vein in the arm. This is actually the preferred long-term choice because it has superior longevity and a lower infection risk, although it does require weeks to mature. Alternatively, there's the central venous catheter. Now this one is ready for immediate use, but it accounts for a staggering 70% of all access-related bloodstream infections. Yet, despite those extreme infection risks, a lot of patients still absolutely have to rely on them.
And this brings us to a very real, relatable limitation. Why can't dialysis patients with a central venous catheter go swimming? I mean, it seems like such a simple summer activity, but it really highlights a profound loss of freedom grounded in raw human experience.
The reality is, a catheter is a direct, permanent line right into a patient's heart. The severe infection risks require the catheter to be sealed with a specialized lock solution between treatments. This usually contains anticoagulants, like heparin, and antibiotics like gentamicin. Now, this does prevent fatal bacterial growth and thrombosis, for sure, but it makes the patient incredibly vulnerable and imposes really strict lifestyle limitations. Swimming is literally just too dangerous.
Section 4. The heavy human toll. The exhausting reality of chronic treatment.
Now, what's really interesting about the data here is how we pivot from the clinical science to the profound psychological complications of this life-saving therapy. There is an incredibly stark contrast in the mental health data. Clinical depression rates in the general population sit between 2 and 9%, but for dialysis patients, it skyrockets to between 20 and 30%. The relentless dietary restrictions, the inability to travel freely, the loss of independence, and just the sheer hours spent tethered to a machine absolutely ravage your patient's mental health.
320. That is the estimated number of painful, thick needle insertions a typical hemodialysis patient using a fistula endures every single year. Let that sink in. It is a constant, unrelenting cycle of anticipation and physical pain that drives severe, chronic anxiety. I want to share a really powerful quote straight from a dialysis nurse in our sources. Dialysis treatment is often an endpoint for many, meaning that future perspectives are limited. A process of grief. As these patients accumulate vulnerabilities and chronic fatigue sets in, the sheer burden of survival literally causes many to simply lose heart over time.
Section 5. Autonomy and Dignity. The Ethical Dilemmas of Life-Sustaining Care.
In our final act of this explainer, we're exploring the heavy, ethical burdens placed not just on the suffering patients, but on the nurses providing their vital care. And this creates a major clash between two foundational ethical pillars. On one side, you have patient autonomy, the fundamental right of a competent patient to choose or refuse their own medical treatments. On the exact opposite side, you have beneficence, the medical professional's ethical duty to act in the patient's best medical interest and essentially prolong life. You can see how this creates deep moral distress for nurses when a competent, yet completely exhausted patient just wishes to stop a life-saving but grueling treatment.
Nurses are often caught right in the middle of this impossible dilemma, as one source noted. The only persons who can stand up for patients are nurses. We are their spokesmen. Nurses effectively act as essential mediators here, advocating for a patient's human dignity and right to self-determination, even when it directly conflicts with standardized medical procedures aimed at keeping them alive.
And as a result, this incredibly intense environment leads to severe burnout among providers. I mean, dialysis nurses aren't just managing highly complex machinery. They're constantly witnessing ongoing patient suffering and deterioration. They're balancing their duty to prolong life against the patient's sheer exhaustion, all while navigating really high workloads with super limited time to actually offer any psychosocial support. Ultimately, their struggle is directly tied to the patient's struggle.
Which leaves us with this final, really provocative question to consider. Where exactly is the line drawn between simply prolonging a life and preserving true human dignity? The hemodialysis machine is undeniably a mechanical miracle, but the human toll it extracts completely redefines what it means to actually live. I really hope this explainer has helped you grasp the profound complexities of renal care, and hopefully leaves you wanting to explore even more.